Um, Dr. Rashma, can you start, ma?
Yeah. Hi. Good evening, everyone. Am I audible right now?
You are audible, ma. Can I just introduce you, ma?
Yes, sir.
Okay. So, good evening. Namaste and good evening to Dr. Rashma, resource person of this evening. This is Nisha from NIMHANS, who is providing online and offline support for conducting the webinar. The enthusiastic and inquisitive viewers and participants of this webinar from across the country. I have great pleasure in welcoming you to yet another edition of this webinar, being organized by Vayomanasa Sanjeevani, an outreach arm of Geriatrics Department of NIMHANS, Banglaore. I would like to provide a brief overview about Vayomanasa Sanjeevani. Most of us know about National Institute of Mental Health and Neuroscience, known as NIMHANS. It's a world renowned as a center for mental health, neurosciences, and allied field. They have geriatrics care as a specialized field, and in that department, they have started this webinar service to create awareness to people at large about the developments in the field so that they can be benefited. I am happy in welcoming and introducing to you Dr. Rashmi MD, the resource person of this evening. She is young, highly educated, and experienced doctor. After finishing her MBBS degree from KS Hegde Medical Academy, Bangalore, in the year 2017, she continued her education and obtained her MD in psychiatry from the same institution in the year 2023. Thereafter, she has joined NIMHANS as a senior resident. As regards her experience as a specialist, she is working as a senior resident in Geriatric Psychiatry Department of NIMHANS in a project known as National Telemanas Program. Telemanas initiative has been launched by Ministry of Health and Family Welfare during October 2022. It aims to provide free telemedical health services all over the country around the clock, particularly catering to people in remote or underserviced area. One can call the toll-free number 14416 or 180089144416 for assistance. We need to know that Telemanas is not restricted to any senior citizen. It is open for all citizens of the country, and it is available in multi-languages. Telemanas provides services to people who are experiencing exam stress, familial problems, substance use related issues, relationship issues, memory problems, financial stress, any other mental health concerns and issues. She is serving as a Tier 2 specialist for helping persons with mental illness and other Telemanas callers by offering audio and video consultations, including night calls. Because she is overseeing the duties of lay counselors and networking with services already in place throughout the state, especially with Tier 3 staff at the district levels. She is experienced in clinical setup, OPDs, and emergency duties on rotational basis. Her areas of interest within psychiatry are liaison psychiatry, community psychiatry, child psychiatry, perinatal psychiatry, forensic psychiatry. Her participations include organizing several seminars on mental health issues at various places. Paper presentations on several topics in such seminars, chief among them being many phases of brain tumor, frontal lobe meningioma, disguising through late onset of cancer through psychiatric symptoms. So mental cancer also she is dealing with. In her various roles, Dr. Rashmi has come across many seniors experiencing mental issues. Today, she has agreed to talk to us about the major mental or psychological issues encountered by seniors and solutions offered to them. She has been requested to give her suggestions about best practices that would avoid any kind of mental stress for the seniors. I understand that the important reason for her to choose this field of super specialization is her desire to serve the disadvantaged poor people who seldom understand the psychiatry and mental issues in the proper perspective. I appreciate her for her bold decision to specialize and serve people who, according to me, is not a favorite section of the society for the medical field. I may add that she has been very active from the student days in organizing meetings in this field, and her teachers in her medical college have provided her with a lot of motivation for choosing psychiatry field in preference to various other more lucrative medical specializations. Dr. Rashmi is a trained Bharatanatyam dancer. As a time management tool, I request participants to type their questions, if any, in the chat box for her to answer. You may also raise your doubts after the resource person finishes her presentation. Yes, Dr. Rashmi, we thank you for your desire to share your knowledge and experience with us today by spending your valuable time. As far as we are concerned, we are a set of mostly senior citizens who like to know from experts like you the issues involved in mental issues involved for senior citizens and the types of problems that the types of solutions that we can give, we can provide to people, or we can also take from people. So we do not like to, depend on the WhatsApp University knowledge. We like to hear from experts like you. So we really thank you. We feel that we are fortunate to hear from you, an expert on important topic of common mental health problems in elderly. Please go ahead with your presentation. Thank you.
Thank you for your kind words, sir.
It's not, I have not exaggerated anything, ma'am. I have just provided whatever I have known about you. That's all.
Yes, sir.
Thank you, ma'am. Kindly go ahead.
Okay, sir. I am trying to share my screen now.
Please, ma'am. Please go ahead. Well, you can go to presentation mode, ma'am.
Yes, sir. I'm trying that.
Yeah. No, take your time, ma'am. Absolutely not.
Yeah. Is my screen visible now, sir?
Fine. Absolutely.
Yes. So, good evening, everyone. So, my name is Dr. Rashmi, and today I'll be presenting a small talk about common mental health problems in the elderly population that we have come across as residents in psychiatry throughout our MD and now in senior residency. So, who is an elderly person in India, as per to you?
So people can respond. You can, unmute and respond, sir. People, anybody who likes to respond.
So, who is likely to be a senior citizen or an elderly person, at least in India?
Anybody with age of 60 years and above.
Yes.
Age of 60 years and above.
Yes. So, as per various laws such as Maintenance and Welfare of Parents and Senior Citizens Act 2007, so elderly is anyone who is above the age of 60. So 60 years and above is considered a senior citizen. So, but mostly age is a social construct. So how else can we define someone as elderly?
What is the other criteria? See, somebody who is not able to, take care of himself, live
Yes.
by himself, who is finding difficulty in her day-to-day affairs, carrying out day-to-day affairs.
Yes, sir. So we can also define someone as elderly as by the roles that they have taken up, such as becoming grandparents, or it could be retirement from a long-term job that they were carrying, or cessation of certain roles. That is, all these while the person was the earning member of the family. Now they have retired from the job and they have continued to be a person in the house. So, elderly, as per our definition, because the MWPSC 2007 says, is someone who is 60 years and above. Now, what happens when a person gets old is that a person will endure physical changes. That is, there is a lot of bodily changes happening, right from the skin to the internal organs. But something that we should also focus on is the psychological and the social changes that is happening to the person, around the person, whatever the changes are happening in the society as well as in the mind are also important as we grow old. Now, coming to what happens in mental health concerns in elderly is that it is usually underdiagnosed. So I do not want to go much into the statistics or how many numbers of people are affected because that would be too much over here. But I would rather focus on why is that the mental health concerns of elderly is usually undiagnosed or underdiagnosed is a lot of times what happens is the psychiatric symptoms that the elderly people present with, the attribution of the symptoms is to something else. For example, the person comes with sleep disturbances, we consider it as something as age related. It could be a symptom of a depressive disorder, or it could be an independent sleep disorder per se. Then, secondly, there is cognitive impairment happening as a person grows old. And what happens is the features of cognitive impairment, like forgetfulness or irritability, also can be confused for psychiatric disorders and vice versa. Then, apart from that, we have certain physical disorders that also present with psychological distress. So, sometimes what happens is if the elderly person is also suffering from, say, diabetes mellitus on a long term or thyroid dysfunction for a long term, even they can also present with psychological symptoms. And it could be a part of normal aging. And most importantly, the book that we follow, the ICD book that we follow for diagnosing psychiatric conditions in India, the book has lack of age appropriate diagnostic criteria. So we define certain person to have a psychiatric illness by certain amount of symptoms for certain duration, but there is no consensus on what age group falls for those criteria of symptoms. And lastly, there will be forgetfulness and social stigma associated with the mental health concerns. So, because of all these factors, what happens is most of the times the psychiatric symptoms are usually overlooked, or we end up not identifying them for a really long time. Now, the social changes that mainly happen, and also these have a significant role in a person when they develop psychological issues, include mostly retirement. So this will cause a significant change in a person's lifestyle. Let's say now Mr. X, who has been working from the age of 21, he has been the sole breadwinner of the family. He lived a very content life for almost 39 years in service, and he's told to retire at 60. All of a sudden, he may feel that he doesn't have a purpose because all these days he was looking forward to going to work, providing for the family, and suddenly the role has stopped. And this can cause a lot of boredom, and the change of role of not being the breadwinner of the family might bring some discomfort to Mr. X. Then, apart from this, we also have seen elderly people deal with the death of their spouse who have been together for decades, or other family members, maybe siblings or cousins, friends, the peers with whom they went to school, college, or they were working along with. Dealing with the grief also gets difficult. Then sometimes the change in place of residence, home, and other positions. For example, all this while, Mr. X was staying in South Bangalore. And now, because his children are employed in somewhere in northern part of India, Mr. X and his wife are expected to move to northern part of India because they would have to live with the son and the family. Now, the change in place also will bring the discomfort because for the last 45 years or 40 years, he was living comfortably in a familiar environment with the people whom he knows. And there will be changes in income because pension money or being dependent on other family members, again, this will restrict the amount of resources they have. And lastly, an individual is likely to get dependent for activities of daily life because as we grow old, we'll have impairment in our sensory abilities. We may not be able to see properly, or we may not be having that much of mobility as when we were young. And what happens is at this point of time, even though physically we feel restricted, there's a chance that we feel that we are a burden on our children or anyone who is looking after us. And again, it causes a lot of adjustment issues. However, the mental health concerns that are very common in elderly that we are coming across, and also these happen to overlap with one another, mainly include depression. Then we have dementia, which is also associated with memory, anxiety disorders, sleep disorders, substance use, and others. Now, coming to late life depression or major depressive disorder in the elderly. So, what we have commonly seen, we have heard about depressive disorder is that people feel sadness. In the elderly, however, they report more of feeling empty rather than sadness. The emotion is usually irritable rather than being worried and feeling sad, and they can be more agitated. That is, they feel restless at one place and they keep moving from one place to another because they are unable to sit on one side. The thoughts usually include nihilism, that is, they feel that there is no purpose for anything, there is no purpose for the world, they have no purpose, and everything is going to cease to exist. There will be usually the denial of the above mentioned symptoms also. Like if you inquire with Mr. X, if he's experiencing these symptoms, he will end up denying the symptoms or he will minimize whatever he's feeling. The speech is always low. You cannot hear how they speak, or you cannot understand what they are trying to say because the pitch is very inaudible. And no matter how difficult it is, they refuse to take help. They would rather, because the feelings of nihilism, the feelings of feeling worthless or hopeless sets in, what they end up doing is they rather isolate themselves from the others than seeking actual help. So these are the common symptoms of depression in elderly as compared to someone in their early 20s and early 30s who also present with depressive symptoms. Now, something that is commonly seen in parents, elderly parents who also happen to have depressive symptoms is the empty nest syndrome, who experience feelings of grief, loss, fear, and inability in difficulty in adjusting roles, especially when the children leave the parental home. We have seen this typically when children move abroad or if the children are married off and live in a far off place than their actual place of residence. Now, something else that I would like to add about is grief, which is usually something that comes after an unpleasant event. Now, how do we differentiate grief from depression in the elderly? Is the depression is mostly associated with other changes that are experienced in the person's body. That is, as gradually the feelings of uh, not being worthy or feeling helpless sets in, the biological changes such as disturbances in sleep, reduction in taste, and reduction in energy levels also set in, which is not classically seen in grief. And also, we see that grief usually gets better with time, maybe sometimes 6 months or more. So, What happens is when a person is having depressive disorder, especially in the elderly, the isolation will worsen the depressive symptoms, which will further worsen the isolation, and the cycle keeps continuing. So, identifying somebody with the depressive disorder gets very important over here. The next medical condition that is actually associated with psychological disturbances is dementia, which is classically we call it as global cognitive impairment. In simple words, if I have to say, as I grow old, my brain shrinks by size, by volume, and by its functioning. So, what happens is the changes that I'll experience is in my memory. I'll have difficulty in naming things, I have difficulty in speaking, and there will be certain changes in my behavior and personality. As a result of this, I'll have difficulty in carrying out routine activities, including that of self care, like bathing and brushing my teeth. Now, commonly, the elderly people who have dementia, who develop behavioral and psychological problems, they present with restlessness, they present with agitation and aggression. Aggression is usually commonly seen towards their immediate family members, like spouse or children. There is critical and stubborn and demanding behavior. Sometimes there is wandering away from home. The person intends to leave the house, but he is unable to reach his destination. So there is a possibility that he may wander off to another place. There is disturbances in sleep, there is lack of regard to the societal norms, and sometimes there can be major psychiatric symptoms in terms of hallucination. In Kannada, we name it as Brahme, where a person will be experiencing things that others cannot. So he may see things that does not actually exist, or he may hear things that may actually not exist. And there may be delusions, which is basically the person has a very false, unshakable belief that something bad is happening or someone is definitely trying to harm him. And all the behaviors will be associated with these symptoms in patients with dementia. The next thing that is very commonly seen in elderly, which we often see actually even in the age in younger people, but it is commonly seen in elderly, is sleep disorders. So I had a patient, Mr. X, who had a healthy lifestyle with no medical comorbidities, and he would say that, Madam, all these years I was able to sleep by 9 p.m. and wake up by 5 a.m. Now I go to sleep at 8:30 p.m., but I am not able to sleep at least until it is midnight, and I wake up by 4. So what is happening? Why is it happening? It's been almost 6 months that I've had a good sleep. So the sleep disorders, usually what we see in elderly is insomnia. It can be physiological. That is, as we grow older, the need for sleep also reduces. Sometimes even a sleep of 5 to 6 hours is also enough. Or it could be because of the physical causes. That is, if I have a medical condition that is ongoing, which is not under control, that also can reduce my sleep. If I have injured my leg or if I have a chronic back pain, that can also disturb my sleep. Then psychiatric causes like having depressive symptoms or dementia or other substance use issues also can disturb the sleep. And environmental factors like excessive light, loud sound around the house, uncomfortable beddings, these can also cause disturbances in sleep. Now, something that is often seen in elderly is the medications that are causing disturbances in sleep. So, we have seen elderly people taking laxatives, especially when they have constipation, and sympathomimetics, that is, people who have to take certain type of drugs to keep their heart and lungs intact, or if they have the habits of consuming coffee related beverages, coffee, tea in the evenings, or anti-Parkinsonian drugs, that is your levodopa, amantadine, carbidopa, etc. These symptoms also can make the person very aroused and disturb the sleep at night. Then, most important but most often overlooked problem that we see in elderly is the substance use disorders. So there's a lot of contributing factors to it from the society as well as the coexisting illnesses. So For example, now a person with diabetes over a period of time, because the sugars are not controlled, will develop certain type of pain. He may complain of pain in his hands and soles, or he may complain of some disturbances in the digestive functioning. So the easiest way to cope with pain or sleep disturbances is resorting to substances, which ultimately becomes dependence for the elderly person. So we have seen quite often seen elders resorting to alcohol for a better sleep or to relieve pain, taking tobacco products, especially oral tobacco and cigarettes, to keep the mind active. And opioids are commonly prescribed painkillers that often elders end up abusing in a regular basis because it relieves pain and gives us a feeling of calm. The next set of problems that we see in elderly is usually anxiety disorder. So, anxiety is a constant state of worry without any specific reason. So, this can be a generalized anxiety where the person is worried for almost most of the day for a very long time, or he could be afraid of a particular situation. Like elderlies, we have seen quite often that they are afraid of, they have phobia of open space. They are very reluctant to go to crowded space or go to market areas, and it's mainly associated with the fear of falling or injuring themselves or falling extremely sick in such areas. Then there can also be persistence of obsessive compulsive disorder. That is, a person has same thought that is repeating again and again in his mind, which relies only on acting on the thought, and the stress is relieved. They can also have panic disorder, which is anxiety, but more of an episodic pattern. Or if we have seen commonly in war veterans or in army generals, where they also happen to have post-traumatic stress disorder. That is, they tend to relive the moments of the unpleasant situation that they have come across. Now, the symptoms of anxiety disorders mainly include excessive worry and like physical symptoms like always the heart feels racing, mouth feels dry, hands are a bit shaky. We call it as tremulousness. There is a sense of unease in the chest. These are the physical symptoms of anxiety along with the constant state of worry. And sometimes the symptoms of depression, anxiety can overlap.
One second, ma. This obsessive compulsive disorder. Can you
Yes, sir.
elaborate a little more, ma?
Yes, sir. So, obsessive compulsive disorder comes on the spectrum of anxiety disorders. So, here a person has a thought that is intrusive. That is, he does not want the thought in his mind, but the thought keeps coming in his mind. For example, my table is dirty. This thought keeps coming in his mind. Now, in order to get rid of the thought, what he does is he cleans the table. That becomes a compulsion. That is, he's doing it because he wants to get rid of the thought. And if he doesn't clean the table, he has a lot of anxiety because he feels the table is dirty. But he knows that this thought is irrational. It does not have any basis. It is intrusive. It is affecting his daily life. So, obsessive compulsive disorder involves a set of symptoms that are intrusive, repetitive, could be thoughts, it could be actions, or it could be images. Most commonly, we see elderly people who are having obsessive compulsive disorder. They usually have these repeated thoughts about dirt, and they have repeated thoughts about checking. Have I locked my room? Have I closed the window properly? Have I kept my money safe? These are the commonly seen obsessive compulsive disorder symptoms in elderly. Can I move ahead, sir?
Please, ma. Please go ahead. That helps me. That helps.
Yes, sir. Then other psychiatric disorders that we see, but it is mostly associated with the other comorbid psychiatric illnesses include psychosis. That is, the person can have delusions and hallucinations and behavioral changes, which may or may not be attributable to a condition that is ongoing in the brain. So psychosis is usually independent of a brain pathology. Then we have an entity called as bipolar disorder, where a person has extremes of mood symptoms. That is, on one side, we have depressive symptoms, and on another side, which is characterized by elevated mood, increased energy levels, and reduced need for sleep. This is called as mania. So, this can also occur in the elderly people. And we have certain personality traits and disorders. That is, we are likely to see some people being narcissistic about themselves, or some people might be avoidant. They would be avoiding people in general, or they could also be having something called as an anchasm. That is, they could be too perfect. They would want everything in an orderly manner. So these kind of personality traits also can increase as they grow older, or it can become a disorder per se. But we do not see this more as common as the ones that I have mentioned earlier. Uh, and the last thing that I would like to explain about is elderly abuse. So, when do we suspect elderly abuse? Is because elderly abuse is that is most commonly comorbidly happening along with the psychiatric disorders. So, if a elderly person presents to me with unexplained injuries or frequent injuries or injuries that are too obvious to notice, and there is a marked distress by the person when the caregiver is around. Here, what happens is I have seen that the elderly person is too guarded to speak, and the speech is usually restricted to one or two words in the vocabulary. There is not much of gestures in their speech. They would avoid eye contact, sit in a very timid posture, and the caregiver is usually impatient with the person and has probably some behavioral issues or substance use. This elderly abuse can happen in the family context. It could be a physical abuse where the person is hit. It could be psychological, where they are deprived of their psychological needs, the emotional care and support. It could be financial abuse or even sexual in nature. So, usually, as much as possible, we try to report to the authorities or provide them with the necessary help when we come across such abuse. But often, when we see elderly patients with mental health concerns, elderly abuse is something that we have to look for and also inquire about. And we usually get this information by bringing the person into our confidence and absolute privacy. So, how do we approach an elderly with psychiatric or behavioral disturbances? We all have grown up in families where there was some elderly person after a certain age. We have seen the person having some difficulties to carry on. So how do we approach these kind of scenarios? Or how have you dealt in the past?
Behavioral disturbances. Yes. See, but whenever first we have to gain their confidence now.
Yes, sir.
We are there to help them and not to find fault with them. And they can share their grievances directly with us so that we will be in a position to understand their condition and help them. That kind of confidence building is the first step now.
Yes, sir. So what happens is we have a lot of senior citizen population now all over the world, not just in India. And loneliness and feelings of isolation is something that we all dread, and COVID has made it worse for every one of us. So, what happens is confiding these issues in a person becomes difficult. We will not have the confidence, will not have will not feel safe that, yes, I may confide in this person. So, ideally, what we do is that when we come across such people, we ensure that there is adequate privacy. That is, we have closed cabins, and we only keep the person who is affected and, if needed, the bystander. So we usually carry on with the one-on-one session, empathetically listen to what the person says, because sometimes I have seen the elders respond very well by just validating their concerns, by making them uh, understand that, yes, we are there to listen to them, we can understand what they say. And we should also keep in mind that these elderly have physical difficulties when it comes in terms of the vision or hearing. So it's good to speak slowly and clearly and repeat if needed. Also, it's important we need to identify if what I am saying, the person is able to understand and comprehend, and they're able to identify the people correctly. This also helps in identifying if the person is having any confusion or any disturbances in their cognition. We also assess for the social support, and by social support, it's not just the children that are around them, it's their entire family, their neighborhood, the society they are living in, and how they perceive the available support. What is the attitude of the support towards the person, and what is the attitude of the person towards the support that is available? And we are usually empathetic and affectionate, and also identify if the substance use that is contributing to the current situation. And as much as possible, the easiest thing that one can do when we come across a person with behavioral disturbance is to refer them to a doctor. So it need not be a psychiatrist in the first place. You can refer them to a a general physician, and you can then further refer them to a psychiatrist or a neurologist based on the need, how the situation is present. So what happens here is identifying that a person needs help becomes important, and for the person who is going through this, or if we know someone who is going through this, if we follow all these steps, it will be easier for an elderly person to approach the necessary help, or at least receive the necessary help. So now everything is easy to speak as a doctor for me, because I can tell that you have to be empathetic towards the person who is suffering, because they are not aware of the things, or they are going through changes which is difficult for them. But also it is important for me to acknowledge that the caregivers also feel tired sometimes. They also sometimes want to ventilate. So it's equally important for us to listen to the caregiver. It could be the spouse of the person, it could be the children, or it could be the family member who is taking care of them. And we reassure the families that these behavioral changes is a part of the aging process, and these are happening as a comorbid process. Again, we ensure the dignity and privacy of the individual, and we establish a daily routine that is feasible for both the elderly person as well as uh, the caregiver. So some of the safety measures that we tell is keeping a chair to sit while bathing, that is in the bathroom, and a mat that is to prevent slipping of the person, or a support rod or a ramp in the house. Now, certain patients, especially with dementia, or if they are having psychosis symptoms, that is wandering away from the house, or some kind of suspiciousness they have, then it is always good to have an identification bracelet or necklace in case of there is history of the person having wandering behavior and being lost from the home. Also, locking the doors in the night in case of wandering is quite useful, and use of bedpan if needed. That is, this will also ensure that the person who has a risk of fall, especially in the dark, using bedpan avoids the mobility from the bedroom to the washroom. So it will be useful in some situations. Now, when the elderly is having anger outbursts or irritabilities, then try to identify what triggers the anger and minimize the situations that triggers the anger. And in case of the person having any irritability, it's better we avoid a confrontation and argument, because sometimes just listening to what they want to express is enough. And the tasks has to be simple. It's like, for example, now if the task is of brushing the teeth, it should be just brushing the teeth, which the elderly has to carry on, and it should not involve any other things like turning after the brushing he has to go and turn on the geyser, or go for a walk. Like, multiple tasks should not be clubbed together. Then uh, if in case, let's say that the caregiver also happens to be occupied with some other work, it's better to have labels in the house, such as So suppose if the person is not habituated to his phone, then label the phone as mobile phone, or label some commonly used grocery items or household items, and using memory aids like labeling the doors to bathroom or keeping signboards in the bathroom along with the current day and date every day also helps the individual when the person is having these concerns. Now, the mental health disorders in older adults, they're a leading cause of suffering and disability in the world. We need to address and cater to the needs of older people and their families. It's quite important that we address it as a whole unit and not just the person. Now, because of advancement in technology, we are able to use both telemedicine and integrate peer support specialists, lay counselors, and community health workers to bridge the gap that is there in the worldwide. So, what happens right now is we have a paucity of psychiatrists per se in India, but apart from that, geriatric mental health clinicians also happen to be on the lower side. So, use of these aids will bridge the gap, and also they help as antidotes to the barriers posed by fear and stigma. So, the person will feel free to approach a person in difficult situations, and also ensure that the help is achieved. So, lastly, that I would like to talk about is the program that I work for, which is Telemanas. The acronym MANAS stands for Mental Health Assistance and Networking Across States, which is a part of National Tele-Mental Health Program initiated by Ministry of Health and Family Welfare. So, this was launched in the year October 10th, 2022. The toll-free number that we commonly use is 14416, which is accessible from any part of India from at any time and available in 20 languages, where we provide tele mental health services in terms of counseling and referral to the nearest district mental health program, that is to a psychiatrist and psychologist in the respective district at the earliest, where on dialing the number, you will have access to a trained counselor who is usually of psychology or psychiatric social work background, and you will also have access to a psychiatrist if needed, who will then connect you to the DMHP team as and when the need arises. So, as a part of my webinar, I would also like to encourage to not hesitate calling Telemanas at any point of time, because we are available 24 hours, 7 days a week. So, with this, I would like to conclude my small talk about mental health concerns in elderly. Thank you.
Thank you, Rashmi. It was a
Yeah.
nice presentation. I think all the people have enjoyed it because that shows they have been very quiet. Therefore, when they are listening so intensely, people do not raise questions. Yeah, but anyway, there is a question in the chat box, Rashmi.
Yes, sir. Yes, sir. I'm going through that now.
Yeah, yeah.
I want to close my presentation actually.
Okay, ma, please go ahead. But can I read it for you, ma?
Yes, sir. Yes, sir.
Parkinson's handling is not easy.
Yes, sir.
So, can you give some suggestion to handle these types of clients?
About Parkinson's.
Yeah, yeah. How to handle a person, how to take care of a person with, Parkinson's. See, I agree with you on one point. This caregiver burnout. This is
Yes.
something that we often come across. In fact, you talk to any caregiver, especially the family members, they have all kinds of stories to tell. In fact,
Yes.
most of them are also true. We cannot find fault with them.
Yes.
Because, all 24 of us working with people like with some difficult conditions is quite difficult. I understand. But still, I think this is also, this person was a very useful person some time back. The same person has now turned out to be like this. So when he was very good, you enjoyed him. You enjoyed because of him. Therefore, you have to take care of him. That is one type of attitude. The
Yes.
other type of attitude is that no, see, I have also suffered like him. During his earlier years, also, I have taken care of him. Therefore, it is not difficult for me to take care of him. So this kind of arguments and counter arguments, presentations go on. But in such a situation, how to take care of the caregiver? That was the question raised by him. Yeah,
Yes.
you can just give your valuable advice on that.
Yeah, yes, sir. So, basically, the understanding of what Parkinson's disease also plays a very important role. So, Parkinson's usually is a degenerative disorder. So, what happens is there are certain chemicals in the brain that is affecting the person's mobility. Even the smaller mobility movements are also affected. Now, the concerns that comes along with Parkinson's is because it affects the whole of brain. There is also some coexisting psychiatric symptoms which can happen because of the changes in the brain, which can also happen because of the medicines that they take. We have often seen that patients with Parkinson's disease have secondary depressive disorders. So, in such case, the treatment of the depressive symptoms becomes priority for us. Now, when the caregiver experiences the same, we have actually taken the caregiver in confidence, and we have requested the caregiver to ventilate the concerns that they have. And we also have tried to assess if the caregiver also is going through any psychological distress, right from adjustment disorder to a full-blown depressive or anxiety disorder, because secondary to the helplessness that the person experiences, sometimes even the caregiver ends up experiencing the same symptoms. So, what they feel is, if I am not able to take care of the person, who else will? And why am I not able to take care of this person? The difficulties tend to overtake the thinking of the person, and then ultimately the care that is supposed to be provided gets affected. So ideally we have to assess mental health concerns in the caregiver also when we are assessing for the same in the patient.
I understand. So Parkinson's, can you like to throw any other, specific guidelines on that to take care of a Parkinson's person?
Yeah, yes, sir. So the thing is, Parkinson's disease, the medicines that are given, these are given at specific intervals. I hope, so they will be given the levodopa tablets probably 6 times in a day or 8 times in a day, depending on the severity of symptoms. So what happens is when the effect of medicine tends to reduce, the movement becomes more difficult for the patient. So at that time, it is better to keep these supportive aids throughout the house. That is, the railings for support, or ensuring that there are sufficient cushion chairs around to prevent falls of the individual. And also, it is better that we give the medications to the patient and patient not take by themselves, because sometimes patients end up abusing the medications of Parkinson's disease. So, apart from that, we can also ensure that the patients of Parkinson disease have a routine. That is, even when the effect of medication wears off, that's when the difficulty in movement as well as the sadness sets up. It's better we engage them in activities that are easier to carry out, or make them present in situations that they are comfortable with. So this is how we can care for the person with Parkinson's disease, and it's always wise to ensure that, like, if the caregiver feels burdened, then to share the caregiving task with somebody else who is consenting for the same and who is acknowledging the concerns.
No, that's a very nice suggestion. For that, try to, take the support of another person also. In that
Yes.
context, I think networking with the people who are doing similar jobs. Network of all the caretakers, caregivers, etc. I think now
Yes.
several associations are available for them. I think supposing somebody joins that association, therefore they can exchange knowledge about things, and they can understand how their particular problem is faced by them, solved by them, etc. That also
Yes.
gives lots of insight into that. Will that work, ma'am?
Yes, sir. Can you repeat it?
Yeah, see, but networking with caregivers. See, there
Yes.
are some caregivers associations available. The persons who are giving care for these Parkinson's or for any kind of disorders. So they have got small associations, either at the local level or at the global level or something like that. So if they can join together in such associations, and if they exchange their knowledge with them, that will also help them to understand how the same situation is dealt with by a different person. Isn't
Yes,
it? What helps them?
sir.
Caregivers Association is available at Salem.
Yeah, in fact, not only at Salem, sir, Caregivers Association is now available also throughout the country, and online also. See,
It is being a big advertised in papers and other things. We can choose, we can pick and choose according to the rates fixed by the person and service per hour or a day or hours basis like that. The person, trained persons are also available.
okay, that is good.
We have to share our requirement.
Yes, sir, that I understand. But I was talking about non-financial commitment. I was talking about these caregivers alone forming an association by themselves. And change, and trying to help themselves individually, like our pensioners association or something like that.
Yes, yes. Normally our customs is close relatives are the caregivers.
Exactly.
Actually, now it is not available because they are working anywhere in India or abroad. They are not able to look after the parents, grandparents, etc. The situation is like that.
Situation is like
Now we are tracing paid people as caregivers.
correct, sir. Correct.
Hello, doctor. I have put 2 questions in the chat box. Please.
Yes, sir.
answer.
Yes, sir. I'm going through the questions, sir.
Okay.
Okay, so there's a question about obsessive compulsive disorders. Is that question by you, sir?
Getting dreams during sleep. Does it mean is it a good sleep or first point?
During
And
sleep.
the other question is taking melatonin, which is the over-the-counter medicine. Is it advisable to take it for
Okay,
getting good sleep?
Okay, so sir, melatonin is actually a hormone that is that is secreted by the brain for sleep. Now, compared to other conventional medications that are given to the sleep, it is melatonin is relatively better because it does not have dependency potential. That is, one does not get addicted to melatonin.
Very good.
Yes, sir. So, but I would suggest that because melatonin is again a hormone that is produced by the brain, it is better to consult with the doctor and then take melatonin because there are certain timings from which for which melatonin is secreted from the brain, and the consumption of melatonin in the dinner, like after the dinner, has to coincide with the same. So that would be better advised by the doctor rather than taking over the counter.
Very good. Thank you, doctor.
Yes.
Getting dreams during sleep. Does
Yes,
it
sir.
mean I am getting a good sleep?
So, sir, the dreams actually occur throughout the sleep. Some of the dreams we remember because it occurs during certain phase of the sleep, and some of the dreams we do not remember, but we end up experiencing the physical symptoms. That is, we feel sometimes if we wake up abruptly, we feel happy or we feel scared. So, there is not much of significance of dreams unless it is some repressed memories or thoughts that we have. So, having dreams is okay, sir. Not having dreams is also fine, sir.
Okay.
Now, if it is scared during that dream, getting sleep, then does it affect the physical condition?
Sir, unless so sometimes what happens is we feel so especially if it's something like a nightmare or a night terror where we
Yes.
end up waking up and we feel very scared.
Yes.
So as much as possible, we try to reassure ourselves, or we like take the support of the spouse or any family member that is present in the house. So sometimes when there is an underlying heart condition or respiratory condition, we feel that there might be exaggeration of symptoms. In such case, it is better to consult with your doctor, because here the sleep is getting affected in terms of both quality and quantity. And deprivation of sleep or on a long term is not good. So if nightmares are specifically the concern, it's better to consult, sir.
Oh,
Dr.
thank you, doctor.
One more question from Mr. Nagaraj Rao. See,
Yes, sir.
he is asking, are there any methods to make the motor neurons stronger to improve mobilities?
Okay, sir. Uh,
See, Dr. In fact, one thing I can tell about Mr. Nagaraj Rao, he is a very, very senior yoga practitioner.
yes, sir.
He is already 85, more than 85 years old, and he is conducting regular pranayama sessions.
Yes, sir.
He is a specialist in yoga. So you can also relate this whether there are any yogic studies or anything has been done on that.
Okay, sir. Unfortunately, sir, I have my expertise is not in that area. I do believe that practicing yoga and pranayama and a healthy lifestyle does help with mobility and other biological functioning. So, in case I come across any such studies, I will definitely share with you, sir.
That will be very nice of yours, because he has very specifically asked the question, the motor neurons stronger to improve mobilities. See, he wants mobility to be improved.
Okay, sir.
Mobility is again, the mobility happens because of the command given by the brain, isn't it?
Yes, sir.
It's also some, motor function. Still, the command is given by the brain.
Yes, sir.
Please do inform me if you come across anything. But again and again, this gentleman is asking, Bob G2. Sir, can you unmute yourself and ask the question, sir? Or the memes an area of your expertise? An area of your expertise.
And unfortunately, no, sir. But if any content that is available on media platform, and if it is in the socially acceptable norms and makes the person pleasant, I think it is okay to go ahead with them.
I have raised one question.
Yes, sir.
There are two kinds of senior citizens. Can you see the chat box?
Yes, yes, sir.
Sir, in fact, I am not getting your question in the chat box, sir.
Yes, sir. The
Directly sent to doctor.
Oh, okay.
yes,
Then
sir. Senior citizens of two categories: one who can afford and one who cannot afford, especially in the rural setup.
But we are talking always about the affordable persons
Yes, sir.
having like
So, for this also, I hope the socio-economic disparity comes down over a period of time. And through DMHP, actually, we are trying to mobilize the doctor and psychologists into the community, so that even the person who cannot afford good treatment also is able to receive the necessary help.
yes. The Act 2007 says generally for all senior citizens.
Yes, sir.
There is no discrimination.
He's right, sir. There is no discrimination, I understand, sir. But the Telemanas program actually tries to understand, so it tries to, answer these questions only, sir. Telemanas, anybody can,
Yes.
anybody can phone up. It's a toll-free number, and they also refer the person to the nearest available. So, if in case of need, they refer the person to the nearest hospital, nearest government hospital. So, what other thing do you think that the government can do, sir? Please tell me, sir. What is your thought on that?
Yes. Thank you, doctor. Thank you, doctor.
Thank you, sir.
Yeah, tell me, sir. Tell me. Hello.
Hello, sir.
Yeah, one Mr. Meera not talking.
Hello, sir.
My grandfather, see, in fact, this is the question that has come. My grandfather insists on eating at restaurants at Madiwala, even when it causes bad GIT symptoms. His advice. He says it reminds him of native Kerala, but I am worried about his health. How to go about?
Yes, sir. So again, this goes back to the same circle. After a certain age, we say it in our native that being old is like reliving second childhood.
Yeah, yes,
So,
yes, yes.
yes. So in these circumstances, reinforcement of what is good for the person and what is not good for the person is something that really helps, where we are trying to make them aware of the consequences, but not in a unpleasant way, but where we are trying to tell them that it is for their good, their safe health is what we are trying to do. That is why we are preventing them from eating the unnecessary items that can affect their health. Repeated reinforcement is something that will definitely help, sir.
Okay. And I mean, can you think of any medication also? I mean, can they consult their doctor for this?
No, sir, this is most likely a behavior.
Ah.
So, and we have quite often seen there are patients, elderly people with diabetes who have been told not to consume anything that has sugar or restrict their sugar intake. But we have often seen them slowly sneaking out, eating the carbohydrate-rich products, sometimes coming up with the high sugar. Again, here what happens is, of course, we cannot scold them, but we can definitely reinforce them as to why consumption of such products is harmful to them.
Incidentally, this person also says he loves his grandfather very much. So, I mean, this is the problem. Most of the occasions, we love our people so much, but at the same time, we are not able, that the love prevents us from taking any serious action against them. But
Yes, sir.
at the same time, we want, because of our love, we want them to live for a longer time. But we feel that they indulge in these kinds of activities, their life will be compromised. That is a real issue, man. Anyway, thank you. I mean, on this we can keep it talking and talking and talking. Okay, I understand. So, any other questions, sir? Yes, sir. Please, sir.
Yes. My question is it necessary to go in for a preliminary cognitive analysis in case anybody observes these symptoms that you said?
Um, yes, sir. So, something that I actually forgot to mention about, and now that you have asked me, I will mention about this. So, we come across an entity called as pseudo dementia. Again, it does not mean that the person is faking the symptoms, or making up these symptoms to gain sympathy or gain help. But what happens is certain times, psychiatric conditions or medical conditions will mask the brain's ability to perform tasks as before, and they can present as forgetfulness, irritability also, which is called as classically pseudodementia. It can happen because of depression, it can happen because of certain nutritional deficiencies also. So it is good to have a cognitive screening, not really not a complete assessment, because sometimes it's not feasible, but at least a screening, which usually is done by the psychiatrist when you consult, or you can request for the physician to refer you to the psychiatrist, or request the physician himself to do. We have certain questionnaires that can be administered for a short period of time and see if the person is having a risk of developing dementia, or is having some cognitive impairment or not.
For the best example for the pseudo dementia would be what I read is AAADS, that is age activated attention deficit syndrome.
Okay, sir.
Age activated attention deficit syndrome. In fact, I was under the impression that it may lead to dementia, but 99% of the doctors and the records indicate that it's pseudo dementia and not actually the dementia. Am I correct?
Yes, sir. So, pseudodementia is basically dementia-like symptoms, but it is happening secondary to other processes. So, I have seen patients having hypothyroidism presenting with dementia-like symptoms, or patients having vitamin B12 deficiency presenting with dementia-like symptoms. So, on correcting the B12 deficiency, the dementia symptoms have actually disappeared. So pseudo-dementia is something that we should definitely look for in elderly population. And also it is very commonly existing with depression, where we ask the person what is the date. So in a true dementia case, he will fumble, but he will come up with an answer. But the depressed individual will only say, I don't know, I forgot. These are the common answers that we see in individuals with the pseudo-dementia.
It's
And
it is called Arulo Marulo in Kannada.
yes, sir.
Okay, thank you.
Okay, sir.
So you got what you wanted, sir?
Yeah, that's all.
That's all. Okay.
Yeah,
sir. Okay, thank you, thank you. I mean, finally, I think a few advices. I mean, what are all the best practices that can make a person live comfortably? Can you just allow yourself a few advices?
Few advices. So this will be a paradoxical thing because I have difficulty in practicing the same, but having a lifestyle that has adequate diet and they also where also there is exercise which is in our limitations, spending quality time with the family members and keeping ourselves engaged within the family as well as the society. I think all these factors will definitely contribute uh, to our well-being, and most probably getting over the feelings of isolation and loneliness is something that will definitely help on a long term. So having enough support system, it could be peers, it could be family, it could be the support groups, will also help us overcome these problems or at least prevent these problems from happening.
I think engaging themselves in
Yes, sir.
social activities like helping others, going to the temple, going to the hospital to support patients, anything of this type would and keeping themselves engaged would avoid such small disturbances.
Yes, sir. And also sharing these concerns with the people also, where yeah, I'm listening to someone, or if I want to tell and somebody is listening to me, also will help a lot, sir.
It was a very nice presentation. I really compliment you for the presentation, Madam Doctor.
Thank you so much.
I mean, if there are no other questions, I think we can request doctor to close the show. Is there any other person who wants any other last question? So I think I will now take, because there is no response, I will now take that this is the, we can officially close down the session. So thank you, Dr. Rashmi. It was a wonderful presentation and we enjoyed every minute of it, And see, very rarely we come across that kind of very good presentation from experts. And we really thank you for sparing your time, sharing your knowledge. And these are all the days when we always think of giving. You have given us the gift of knowledge. So we also need to give you a return gift. So because even when you go to your birthday party, you get a return gift. Therefore, our return gift to you is that we will jointly and severally pray for you to Lord, to our gods, and request Him to shower on you and your family all that are best in your life now. And we would soon like to see you as a much higher position, higher scale, and serve the society. In fact, we are really happy that you have chosen this field and you are serving the seniors. You are serving people, night and day. So this is a very good, attitude that you have developed. We only wish that God supports you and gives you all that is needed so that you are able to develop it further and be of use to the society. Thank you. May God bless you, ma'am. Bye.
Thank you very much, sir. Thank you for your kind words.
Thank you.
Thank you, sir. Thank you, everybody, for giving me this opportunity. I would like to thank Department of Geriatric Psychiatry as a whole and my former staff, Dr. Nishi ma'am, who recommended my name to the Department of Geriatric Psychiatry and enabling me to give this talk. Thank you very much.